So over to Dr.
Good
Nikhil.
to go?
Yeah, good to go, Dr. Nikhil.
So, good evening, one and all. I welcome you all to this Innovations in Hematology webinar series, where every month we have a webinar exploring a novel therapeutic or diagnostic option in the field of hematology, where we have experts in the field speaking to us on the topic, followed by a very interactive question and answer session trying to elucidate practical solutions for the problems that we face in our routine day-to-day practice. So we at Fortis Institute of Blood Disorders are a group of 9 hematologists, both adult and pediatric side, who perform more than 200 to 250 bone marrow transplants every year. The team headed by Dr. Rahul Bhargav, who is the principal director of hematology, and other colleagues. We do cutting edge work in the field of hematology, and Dr. Srinidhi has been spearheading the efforts to build up a molecular hematology program where we have been having an NGS technology in-house where we get our NGS reports in 3 days instead of 3 weeks, which was the standard before. And we have also been venturing into newer technologies and exploring options like ctDNA and PCRs and other options for our Indian patients. So in today's webinar, we would be discussing about the role of ctDNA in lymphoma, which we strongly believe holds a lot of potential for the future. And this could go a long way in meeting the unmet needs in the field of lymphoma prognosis as well as diagnosis. So circulating tumor DNA, as we all know, is an unexplored part, and till now, PET-CT has been the only way to monitor patients on disease. But it comes with its own lacunae that we often diagnose patients very late, especially when they relapse. So can ctDNA act as a powerful prognostic tool and help us to guide our treatment decisions in future before overt relapses, something analogous to MRD in the field of leukemias? This is something which would be very exciting to know. And we have eminent speakers who have done path-breaking research in the field of ctDNA. So today we have Dr. Umberto Malapelle, who works in the Department of Public Health, University Federico, Naples, Italy, Associate Professor in the University of Naples. He is a Deputy Director in Oncology and Hematology Critical Reviews, and he's also the Chair of Young Investigators of International Society of Liquid Biopsy. His main research areas involve the field of genomic biomarker validation and testing for predictive information in the field of lung cancer, metastatic colorectal cancer, melanoma, breast, and GIST. He has developed skills in tailoring NGS assays for a number of different applications, including a special focus on simultaneous detection of clinically relevant alterations like EGFR mutations, ALK translocation. These are used in the routine setting, including handling of different sample types, including both tissue as well as liquid biopsy specimens. So we are glad to have with us Dr. Umberto Malapelle for delivering this lecture. We also have Dr. Francesco Pepe, who is an assistant professor in the anatomic pathology in School of Medicine, University of Naples, Federico. He is a main investigator in the field of genomic biomarkers, aimed to validate and test new generational technical approaches for molecular diagnosis of lung cancer, metastatic colorectal cancer, melanoma, breast, ovarian, and other malignancies. He has developed skills in customizing next generation assays to cover clinically informative molecular alterations on real world samples of the routine setting, which includes handling of sample types such as tissue and liquid biopsy specimens. Before I hand over the session to our eminent speakers, I would like to invite Dr. Srinidhi to share our experience so far in the use of ctDNA in lymphoma patients.
So hello everybody. And pardon me for my voice, but then our experience is young because we are a very young lab, and we've just started doing ctDNA and lymphoma. And I put up these 5 cases because these are the 5 cases for whom we have the data on the response on a PET scan or a clinical response. So these 2 patients have been on CAR T therapy. The journey of one patient is illustrated in the figure in the right side panel, and you can actually see that the pre-infusion ctDNA has reduced at 4 weeks post CAR T and 8 weeks post CAR T, and even the TP53 mutation VAF has become undetectable. Although now we are a little faced with a complex situation that his PET scan, the recent most PET scan, which is not there as a part of this figure, is showing a response, but his ctDNA level stays the same, and the TP53 is now 0.1% VAF at a depth of coverage of 70,000 x. So this is where I would want Francesco to actually, share his experience that what does this actually mean? Because we are new to this, we want to know what to do with it. And then we have 2 patients in chemotherapy whose graph I'll just show you in the next slide. So patient number 1, that is the blue line. If you see, he's having a waxing and waning kind of a ctDNA level despite the response on ultrasound and PET. And similar, the second patient also. So in such patients, I would want to understand that how do the dynamics of these fragmented ctDNA, how do they work, and how should we interpret this? Because we are a little confused that, in the sense, if the PET is showing a response and ctDNA is showing an increase, what does it mean? Should we expect an impending relapse, or is it something which can be false positive as well? So over to you, Francesco. Waiting to learn a lot from you. Thank you so much.
Thank you, Dr. Srinidhi, for sharing our data on this. I'm very sure, and all of us are excited to listen to Dr. Francisco on his approach to ctDNA in different types of lymphoma. So I'll stop sharing my screen and over to you, Dr. Francisco.
Hi, everyone. For us, it's a pleasure to join to this meeting. Are you able to see my screen?
Yes, your screen is visible.
Perfect. Perfect. I'm Francesco Pepe. I work at the University of Naples Federico II, and I would share with you our experience about the use of liquid biopsy in our diagnostic routine practice. And in particular, I would discuss with you about the role of ctDNA in the management of Hodgkin lymphoma patients. Because we are actually employed in an activity with our hematology group, and for this we would try to develop to customize an NGS panel to evaluate the molecular evolution of these patients by adopting an NGS system. But before to talk about this topic, we would focus on liquid biopsy, because liquid biopsy may be considered the preferential tool to be applied in this setting, because liquid biopsy represent one of the diagnostic solution to perform a molecular test. In this slide, we have represented the series of diagnostic routine samples that we manage to perform a molecular test. And as showed by this slide, each diagnostic routine sample is affected by limitation and the point of strength. In particular, these limitations are mainly related to the high fragmentation rate of nucleic acids that we can observe in tissue specimen, in particular surgical resection, tissue biopsy, or cell block. But from the other side, if cytological specimen or liquid biopsy does not affect by this point, liquid biopsy in particular is affected by a low abundance of ctDNA, a low abundance of our analyte to successfully perform a molecular test. In addition, liquid biopsy in particular may be very helpful to dynamic evaluate the molecular evaluation of lymphoma patients, because with the liquid biopsy specimen we have the possibility to inspect the molecular assessment of our patients by approaching a longitudinal series of a plasma specimen in order to correlate the molecular information with the clinical information for each patient. To date, liquid biopsy is a promising tool to perform a molecular test, but in some fields we have yet demonstrated the role of liquid biopsy to molecularly characterize these patients. In particular, I'm talking about liquid biopsy for non-small cell lung cancer patients. Liquid biopsy was introduced to evaluate resistance acquired mutation in exon 20 when non-small cell lung cancer patients overcome a first line with the TKI inhibition and showed the clinical progression after the use of first or second generation TKI. In order to evaluate acquired resistance mechanism, liquid biopsy was clinically introduced by international societies. Another setting where liquid biopsy showed promising results was colorectal cancer patients, where rechallenge therapy was under evaluation in order to give relevant clinical information for these patients that resulted negative for KRAS and NRAS at basal setting. In particular, the idea for the implementation of liquid biopsy in colorectal cancer patients is to early detect subclonal population of KRAS or NRAS positive mutated cells in order to better administrate these patients by using a rechallenge therapy. The first setting in which liquid biopsy may be implemented in clinical practice regards breast cancer patients, but differently from colorectal and non-small cell lung cancer patients, in breast cancer patients we should not focus on ctDNA but on CTC, circulating tumor cells, because several studies previously demonstrated the prognostic significance of CTC enumeration counting in breast cancer patients. But despite this application, CTC are not applied in Italy to administrate this kind of patients. But if these three fields represented the major fields in which liquid biopsy may be helpful and may be useful, we should consider the best technological approach in order to evaluate this molecular hallmark. Because if we decide to test ctDNA, we should use high-sensitive technologies like as digital PCR or NGS. But in the instance of CTC evaluation, in this case, we should adopt another technology, other platforms in order to count and measure CTC levels in our blood specimen. From a clinical point of view, at this moment, we are able to cover only a limited section of the clinical application of liquid biopsy, because, for example, in colorectal or non-small cell lung cancer patients, we are only in this part. We are only in this part of this graph where we are able to evaluate clinically relevant alteration in KRAS or EGFR genes that are crucial to establish the best therapeutical choice for the solid tumor patients. But this graph underline the clinical fields in which liquid biopsy may be applied, in particular taking into account the dynamic application of liquid biopsy to study, to evaluate solid tumor patients like as lymphoma patients. We are also able to implement liquid biopsy in order to evaluate molecular response in the field of treatment monitoring, but also to evaluate follow-up for a patient under a specific treatment regimen. This point may represent the major point for lymphoma patients, because liquid biopsy previously demonstrated a clinical role for lymphoma patients to administrate these patients in accordance with the molecular assessment. This graph is also an exercise that underline the interaction between the technical solution, the clinical need, and the role of liquid biopsy. Because in the left part of this slide, we can see some technical solution like as a real-time PCR, NGS, or digital PCR that may be very helpful to evaluate molecular assessment from our target genes. On the right part of the slide, we can see the clinical consideration that we can perform for an explorative and exemplificative case, distinguishing between a high tumor burden patients and the low tumor burden cancer patients. This graph underlines how the interaction between the adequate sensitivity test and the clinical condition in which we can find our patients, we can early predict the evolution of the neoplastic disease by interacting all these features. Because, for example, in the upper part of the graph, when the patient is affected by an high tumor burden, a real-time PCR may be enough to successfully perform a molecular test or molecular profiling. But in the upper part of the slide, when the patient is confined with a low tumor burden, in this case, we need to adopt high-sensitive technologies like as an ultra-deep NGS solution or digital PCR in order to detect very low frequency alteration, able to guide the clinical decision-making for tumor patients. By showing in details the technical parameters impacting on the implementation of the different technical solutions, we can distinguish between old generation technologies and new generation technologies. In particular, all these technical approaches may be also categorized on the basis of the target of molecular analysis, because on the left part of the slide, we can observe all the technical solutions that allow to evaluate point mutation and indels. While on the right part of the slide, we can see all the technical solutions that are able to cover protein expression and gene fusion. All these molecular alterations may be relevant to successfully and comprehensively evaluate molecular evolution of our patients. But across these technologies, it is also relevant to distinguish between Sanger sequencing and old generation technologies with the new generation technologies, because the difference is relevant also in terms of limit of detection, because next generation technologies, next generation sequencing show a limit of detection of 0.01%. That means that we are able to evaluate one mutated allele on 1,000 wild type allele. In addition, also the reference range is quite different among these technologies, and the significant difference may be observed by comparing real-time PCR with NGS, because for real-time PCR, if we adopt real-time PCR, we are able to evaluate a single target mutation, while if we use next generation sequencing, we are able to cover all clinically relevant alteration in accordance with the size of our NGS panel. And in my opinion, we cannot consider a technical solution better than the others. We can also respond to a clinical request by adopting the most adequate technical solution. In particular, if we decide to test lymphoma patients on liquid biopsy specimen, in my opinion, NGS sequencing, in particular, ultra-deep NGS sequencing, are more comfortable, are more conceivable, and more relevant, are more useful to comprehensively evaluate all the clinically relevant molecular alteration. In integration of digital PCR may be also integrated in the diagnostic workflow to test liquid biopsy specimen for lymphoma patients. But from the other side, if we decide to use Sanger sequencing or real-time PCR to evaluate molecular assessment in lymphoma patients starting from liquid biopsy specimen, in this case, we are sure to obtain a false negative results, because the limit of detection of these technologies are not enough to successfully detect all the clinically relevant mutation that we can find, in particular in the monitoring setting. Across NGS platform, we can also distinguish between hybridization and amplicon-based platform, because all the most useful, technically useful, and diagnostically useful NGS technologies may be grouped in these two categories. But in accordance with this differentiation, we can also we are sure that all these technologies, all these platforms may be very helpful to identify high sensitive ultra low frequency alteration in liquid biopsy specimen. In this paper in particular, an ultra deep NGS platform was developed by this group in order to capture very low frequency alteration in the liquid biopsy specimen for lymphoma patients. In particular, the novelty of this approach was represented by the use of biotinylated probes able to capture DNA fragment with high specificity and sensitivity. In particular, the implementation of this technical design reached an optimized adapter ligation. In addition, this approach was also able to reduce the number of PCR cycles, reducing the number of false positive results derived from PCR amplification cycles. And in addition, this design was also able to capture ctDNA fragment ranging from 115 to 200 base pair. And finally, this design was also able to minimize the variability in depth of sequence coverage across the captured region. Overall, this approach was technically validated on a preliminary series and then was validated on a perspective series of liquid biopsy specimen from lymphoma patients, demonstrating from a technical point of view, encouraging results in terms of detection rate of molecular alteration. In particular, this slide overview all the molecular alteration detected on a series of 52 refractory lymphoma patients and a perspective series of 80 patients. Overall, from a technical and a molecular point of view, this panel was also able to evaluate STAT6 as the most mutated genes because a clinical significance STAT6 mutation was detected in more than 40% of cases. In addition, the most prevalent mutated pathway was represented by NFKB, in line with the literature data. Another crucial data was represented by this graph in point D, where the integration of genomic DNA on the previous series of matched tissue specimen of lymphoma patients and corresponding liquid biopsy specimen for ctDNA evaluation demonstrated that a significant difference was observed if we decided to test only genomic DNA or ctDNA. And complementary approach may be very helpful to improve our molecular assessment to administrate this kind of patients. From a clinical point of view, this paper was also relevant because this paper also demonstrated that, as showed by Dr. Shinidi, that this approach was also able to longitudinally monitor the molecular evolution of tumor assessment by inspecting molecular background. Because on a limited series of patients, the authors was also able to demonstrate that at relapse point after conventional chemotherapy approach, a specific and common molecular pattern was also observed. And the clear and specific evaluation of this pattern was also gave us the possibility to track the molecular evolution of these patients in order to guide and modify the treatment decision process in accordance with the molecular assessment. In this trial, the authors also supported and underlined the previously observed information, because also in this case, the integration of plasma and genomic data was very relevant also for this series of patients, where the molecular information that were obtained on all these kind of genes was was amplified by simultaneously tested genomic and ctDNA analysis. But the use of ctDNA in clinical practice is also affected by some limitations that may be observed in each critical point regards the clinical journey of our lymphoma patients, because we can observe limitation and we can observe a critical point in the pre-analytical managing of liquid biopsy specimen, in the selection of the most adequate technical solution, and in the interpretation of the molecular results. This is our workflow based on the integration of semi-automatized and fully automatized NGS system, able to successfully evaluate the entire list of genes that may be relevant for our application. In particular, in the upper part of this slide, we have showed our semi-automatized workflow based on the plasma collection, on the blood collection, the plasma separation, the cell-free DNA purification by using a fully automatized, by using an automatized procedure, and followed by a molecular test by using a semi-automatized NGS system. In the upper part of the slide, we have also showed another approach that we simultaneously use on our diagnostic routine practice, built on the same pre-analytical part, but the main difference was represented by the use of a fully automatized NGS system, able to cover all the technical procedure to perform and to complete molecular test. One of the major challenges in the managing of liquid biopsy specimen was represented by the pre-analytical part, because pre-analytical part may be affected by limitation when liquid biopsy is not managed in accordance with the international guidelines. Because if you work by using vacutainer tubes, it is mandatory to separate plasma for entire blood until 1 hour from the blood collection, because the half-life of ctDNA is more or less 15 minutes. And if you are not able to separate plasma from entire blood in this short time, you risk to improve false negative results. But if you use Paxgene, Streck tube, or other preservative tubes, in this case, you may stabilize your ctDNA until 3 days from the blood collection. If these represent the critical steps for the pre-analytical part, also the technical solution available for the analytical parts should be recorded and should be evaluated. Because across the technical solution, we have previously defined the NGS as the best upfront technical solution to comprehensively evaluate all the clinically relevant molecular alteration across tumor-informed genes included in your NGS panel. But in accordance with the latest point, we can distinguish among different NGS panel in terms of reference range. That means in terms of genes covered by each NGS panel, and in particular in terms of limit of detection. Because to evaluate clinically relevant molecular alteration in monitoring field of lymphoma patients, you need to use very sensitive, ultra-sensitive technologies, ultra-sensitive NGS panel that should evaluate in deep molecular alteration more than a conventional, a common NGS panel. In fact, for this application, you must use capture NGS panel able to analyze in deep molecular alteration, also under 1%, also under 0.1% of mutant allele fraction, in order to capture minimal residual disease evaluation and dynamically monitor lymphoma patients. In our experience, we have previously designed and validated a custom NGS panel able to cover 7 key genes in 7 solid tumor patients. And we decided, after the validation series on tissue and liquid biopsy specimen, we decided to implement this solution in our diagnostic routine practice. This panel was called SIRE, and this panel was able to cover 568 clinically relevant mutations across EGFR, KRAS, BRAF, c-KIT, PDGFR-ALF, PI3 kinase. In accordance with our validation study published on British Journal of Clinical Cancer, we obtained a concordance rate with the corresponding tissue samples of 92%. In addition, on perspective series of liquid biopsy specimen, we demonstrated a specificity of 100% and a sensitivity of 81%. But from our application, we immediately observed the limitation of our designed panel, because this panel was lack of rearrangement genes that are relevant to clinically administrate non-small cell lung cancer patients. And after the first validation of the DNA part of this panel, we also developed an RNA panel integrating the DNA designed panel. And also in this case, we validated on a retrospective series of previously tested non-small cell lung cancer patients our RNA panel, and then we prospectively evaluated the technical performance of this panel on diagnostic routine samples. And also in this case, we reached a concordance rate of 90%. Finally, another challenging point derived depending on the clinical implementation of NGS techniques is the clinical interpretation of the molecular records, because actually the main critical point is represented by the limitation of the is represented by the heterogeneous sharing of the data, because actually we do not have a uniformity of calling the molecular data. In particular, in our opinion, we should harmonize the clinical reports in order to be aligned in terms of reporting of genomic coordinate, reporting of the type and the quality of the molecular information. We should also harmonize our report in terms of technical information that should be implemented in our report. And all these limitations have a critical impact on the clinical sharing of this information, because we should also consider that all this molecular information are transferred in the hands of an oncologist or an hematologist that should administrate in real patients. Another point was represented by the public repository, where all the information, all the molecular information are found, are recorded, because all the public repository are affected by an heterogeneous level of data. Because, for example, if we need to obtain information about CDK4, in this case, only this database show clinical data about this biomarker. If we are able to interpret this molecular the gene with the other database, in this case, we follow to clinically interpret this alteration. Finally, in the last part of this presentation, I will share with you our experience about the development of an NGS panel about the monitoring evaluation of lymphoma patients. This is the dashboard of Thermo Fisher site that gave us the possibility to to develop a customized NGS panel in accordance with our technical request. In particular, by using Ion Ampli-Seq Designer, that is this software, we pre-analytically designed this panel by selecting all the technical information that are required for our application. In particular, in this case, we decided to design a panel able to evaluate human genome and able to evaluate in our application all DNA-based alteration. After the selection of all this relevant information, like as the application type, the DNA type, and the genome to use to match our NGS data, we also included in our panel all the genomic coordinates that are relevant to molecularly evaluate our lymphoma patients. In particular, all the molecularly relevant genomic coordinates were distributed across 52 genes that, in accordance with our hematology group, was enough to molecularly evaluate this kind of patients. And after the in silico validation of this panel, we technically and analytically validate this panel. A challenging point by the application of this panel was represented by the number of pools, because this pool was built on 3 pools, 3 tubes that containing all the primers that are relevant for our application. And sorry for this, because this slide is in Italian, but this is only to demonstrate that the analytical phase was successfully completed, and we harmonized and optimized the technical information, the technical data in terms of PCR cycles, in terms of annealing time, extension time that may impact on the successful of our technical solution. This is the final one of the final slide that show the technical results of the application of our NGS panel of a retrospective series of 8 liquid biopsy specimens collected from lymphoma patients. In particular, in the left part of the slide, we can see a heat map that reflect the number of fragments that are successfully produced and generated from an NGS panel. In the higher part of the slide, we can see all the technical parameters that gave us the information about the successful analysis from a technical point of view. In particular, we obtained a high number of loading wells, and all these loading wells were in the vast majority of cases able to overcome all the technical quality check of our analysis. In the lower part of the slide, we can see other quality check that are mandatory to be inspected before to accept and to validate molecular results. In the left part, we can see the read length of our fragment that is dependent on the fragment size able to cover our panel. In the middle part, we can see the accuracy rate of, in the middle part and the right part, we can see the accuracy rate regarding the calling of our DNA. And as demonstrated by this graph, the accuracy rate is very relevant and is very high, near to 100%. This is the series of our case. And this case was analyzed in duplicates, and this is the panel, this is the fragment length of each duplicate series. And also in this case, we can confirm that the technical acceptability of our results was also specified for all samples. In particular, the mean read length, the number of reads, and the read length histogram was in line with our project. This is the first pre-analytical part. This is the molecular inspection of our data, because all these variants was automatically called by data interpretation software. And as showed by this graph, we should also use a specific filtering approach in order to remove not informative molecular alteration in this series. But all this data support our idea that this panel was technically reliable to monitor these patients and to evaluate molecular assessment on these patients. This is the our pre-analytical and analytical validation on this series. Our aim is to implement this panel on a perspective series on lymphoma patients. And in the next year, in accordance and in collaboration with our hematology group, we will try to implement this patient on a perspective series on lymphoma patients because we are collecting patients and we are selecting the reagents needed to perform this test. Thank you for your attention.
Thank you, Dr. Francisco, for that excellent talk. You covered the topic in a very lucid manner and explained all the intricacies involved in ctDNA measurement. We have a few questions from the audience. Are we good to go? Can you take a few questions? Dr. Francisco, can you hear me?
Yes.
Yeah. And I think Dr. Vipul Seth has also joined us from RGCI. He's a consultant hematologist at Rajiv Gandhi Cancer Institute. So Dr. Vipul, probably you can also join in for the question and answer session. We have a few questions which we have collected from our colleagues across India. So to begin with, ctDNA monitoring, is it for all lymphomas? Can we do it for all subtypes of lymphoma, or is it restricted to a few specific subtypes?
in my opinion, literature data showed a near correlation between the shedding of ctDNA in lymphoma patients. We have obtained from the literature inspection that these data are real, and for this lymphoma analysis, lymphoma monitoring analysis is real. For other application, for other subtypes of lymphoma, of hematological malignancy, I believe that we need other insight in order to see how liquid biopsy may be helpful and relevant for this application, because the shedding of ctDNA in bloodstream is very heterogeneous across tumor type and and also for the patients affected by the same tumor type. For this, the heterogeneous distribution of ctDNA is also a limitation for the adoption and implementation of ctDNA to monitor to molecularly monitor these lymphoma patients. And we should also take in account this limitation, this challenging part when we apply NGS technology to evaluate monitor evaluation of lymphoma patients.
So it applies to all the subtypes of lymphoma, B cell, T cell, non-Hodgkin's. So this applies uniformly to all the subtypes of lymphoma.
We actually, in collaboration with our hematological group, we only focus on non-Hodgkin lymphoma. In fact, this retrospective series of patients that I have shown in the last part of my presentation was only on lymphoma non-Hodgkin patients in order to technically evaluate this panel, because our aim was only to technically evaluate how this panel may drive the clinical decision process for the patients. And after this technical validation evaluation, we can decide to integrate or to upload this panel by integrating other genes that may be relevant for other subtypes. But actually, we have not experience on other subtypes, only on non-Hodgkin lymphoma patients.
And at what time points during treatment would you recommend monitoring ctDNA? Like mid-treatment, end of treatment, or do you use it as an MRD monitoring post-treatment?
This is a very good question, a very important question, because in my opinion, each treatment has an impact on the molecular assessment, because if we have a molecular background, this molecular background is significantly modified after treatment without any difference, with the specific difference in accordance with the specific treatment. In my opinion, the monitoring of the molecular assessment of lymphoma patients maybe should be approached by integrating some technically relevant collecting point. In particular, we should collect liquid biopsy at baseline in order to have the molecular background at baseline, in order to filter the molecular alteration that may be obtained after the treatment. And in my opinion, we should collect liquid biopsy after the treatment in order to compare the novel molecular background with the previously obtained molecular background and identify the clinical informative molecular alteration that may drive the clinical decision making for lymphoma patients.
And in your experience, how well does the ctDNA correlate with the PET scan? So we do interim PET even in non-Hodgkin's lymphoma, DLBCL, let's say after 3 cycles, 4 cycles, end of treatment, we do a PET CT scan. So have you tried to look at the correlation between ctDNA and PET CT scan?
At the moment, we have not this data because we have only technically validated our panel, but this is a secondary aim of for the next year regarding the implementation of our NGS panel. In my opinion, and from my experience on inspecting literature data, I believe that ctDNA may integrate the imaging techniques, because I believe that the integration of the two analytical levels may be also relevant to optimize the clinical management of these patients. Because if we consider that each one of these may represent one analytical level, both technical imaging, both ctDNA. But if we integrate this information, we can optimize the management of our patients.
So I know this would be probably a little too premature to comment about this, but going forward, do you see treatment decisions or clinical trials based on ctDNA? Let's say a patient with diffuse large B-cell lymphoma, post 6 cycles of treatment, ctDNA positive and PET negative. Do you feel maintenance strategies and other treatments can evolve based on ctDNA monitoring and its rise and fall?
I believe that liquid biopsy. I believe that we need to work. I believe to work a lot to implement this data, because I believe that the data about the subcategories should be enriched, should be improved in order to correlate this information, because liquid biopsy alone at the moment is not enough to administrate these patients. And in my opinion, we can consider that the integration may be the most adequate solution.
Absolutely. I think a lot of work is going on in the field, spearheaded by your group. So, going forward as clinicians, very often we are enthused by this fact that we can have a MRD monitoring akin to what we see in, let's say, AML or ALL. But as far as the ctDNA is concerned, how much coverage is good to differentiate between a Hodgkin's and a non-Hodgkin's lymphoma?
I believe that if we talk about technical coverage to successfully interpret a molecular alteration, I believe that we can consider to reach an ultra deep coverage for our molecular alteration. And to reach an ultra deep coverage for our molecular alteration, we must adopt ultra sensitive strategies like as CAPSEC, like as amplicon based solution that should need to reach more or less 5,000 pair of coverage to accept the molecular alteration.
And many of our patients who get a ctDNA or a test may not be able to afford an NGS each time. So, is there a way you can quantify the ctDNA without NGS?
I believe that this is a point, this is an emerging point, because also in the solid tumor patients, we only consider the qualitative information that may derive from the analysis of ctDNA. But in the last time, tumor fraction emerged as a new parameter that may be considered to integrate the qualitative information. And I believe that the quantification, like as the tumor fraction algorithm, may be very relevant. But I also believe that we can integrate the quantification, and we can work to integrate in our NGS panel, in our NGS workflow, the quantitative information of our ctDNA, because we must be sure that our analysis may be not derived from the analysis of hematopoietic and clonal alteration. And we must sure that our molecular alteration are clinically informative. And for this, it is mandatory in the near future to integrate quantitative information like as tumor fraction. I also believe that we cannot we can exclude to fall in the same issue that we meet when tumor mutational burden failed to be approved as a clinical biomarker for non-small cell lung cancer patients, because TMB failed, in my opinion, because this biomarker was only considered from a quantitative point of view. And in my opinion, also in this case, we can integrate qualitative and quantitative information. But from a technical point of view, until this moment, few algorithms are able to quantify, to obtain also quantitative information about ctDNA in addition to qualitative information.
And a very basic question, but how do we differentiate ctDNA from a normal circulating DNA?
Yes,
Like, if you don't have a baseline to compare with, can you reliably differentiate the two?
ctDNA is a small fraction of cell-free DNA, circulating free DNA. And the low abundance of ctDNA in torrent plot is the main limitation that require the implementation of ultra deep NGS or technical solution. ctDNA is a small fraction of cell-free DNA, and we should evaluate only ctDNA. We should indirectly evaluate ctDNA by evaluating specific molecular information, because until this moment, we do not have in our hands extractive procedures that are able to isolate ctDNA, because also when we extract circulating free DNA, we extract total nucleic acids, circulating free DNA and ctDNA. And with an indirect analysis, we are able to evaluate ctDNA by inspecting specific molecular alteration. For this, as you have suggested, the integration of a quantitative information about the ctDNA, like as a statistical evaluation, like as a bioinformatic algorithm able to calculate tumor fraction, may be relevant in order to remove all the not clinically informative molecular alteration.
And should we do a matched genomic DNA to eliminate the confounders?
Yes, we can remove. We should filter out this alteration, because this may be confusive. This may be confused as a clinically relevant alteration. And we should remove this by considering technical parameters like as mutant allele fraction, but in particular, we should remove genomic derived DNA by comparing our molecular results with the baseline. Because if we have in direct comparison between these 2 points, we are able to filter in all the clinically relevant molecular information. And if we will able to integrate in our analysis also the tumor fraction, we will sure that all the information that we have obtained from the monitoring collecting point are tumor related, not clonal hematopoiesis derived, and are not genomic.
And when you monitor these patients serially, what degree of rise or fall would you consider to be significant? If throughout treatment, let's say there is a 1 log versus 2 log rise. So is there any threshold that you're looking at to see whether the rise in ctDNA is significant?
I believe that inspecting a baseline and monitoring point, we can observe a discrepancy of 15-20% in accordance with the molecular background, because it has been established that this percentage may represent the tumor-derived molecular alteration that may be relevant for the clinicians.
Great. I think with that, we have come to the end of questions from the audience as well as what we have collected from our colleagues. So,
So,
Dr. Frank,
can I ask one question?
yeah, please go ahead.
So, Francesco, what if we used something like a fragment analyzer, like a tape station, and we ran what we have extracted, and then we are expected to get probably a step ladder kind of a pattern because we'll have different fragments. And then if we serially monitor the shortest fragment, just a pilot, just a thought which just struck me that, tumor DNA is supposed to be shorter than the normally shedded circuit DNA. So maybe using that concept, will a tape station help? That is my first question. My second question is that when you mean ultra deep sequencing, at what average depth of coverage and what mean molecular coverage are you talking about?
Yes, from a technical point of view, I believe that to monitor molecular alteration, I believe that we need to reach a high deep coverage. In particular, we need to obtain a medium coverage or more or less 5,000 pair in order to be sure that our molecular alteration are real. In addition, our molecular coverage should be also high in order to be sure that the information are relevant. And this is, in my opinion, is a very critical point, because if we decide to use a not technically useful NGS assay, we are able to lose this information, because if we are not able to analyze in deep this alteration, we are able to lose very low mutant allele mutant allele, very low frequency alteration that guide the clinical decision process for this kind of patients.
Thank you.
Thank you.
Dr. Vipul, do you have any questions?
No, thank you. Thank you for the talk. It was wonderful.
So any more questions for Dr. Francesco from any of the participants?
Probably if we get more questions, we can email him.
Yeah, so I think with that, we have come to the end of the question answer session. Once again, Dr. Francesco, it was wonderful having you, and the insights that you gave on ctDNA, the technical aspects, as well as the potential clinical implications that can come in with further work have been very, very insightful. It was great having you, and thank you so much for sparing your time and educating us about this novel intervention.
Thank you.
I thank one and all who has joined us on this Friday evening from India. So we are pleased to have more than 150 to 200 participants from 8 different countries joining in for this wonderful webinar. I thank one and all for sparing their valuable time and logging into this webinar organized by Fortis Institute of Blood Disorders. We'll have the next session this Friday on the 20th, where Dr. Nitin Jain will be speaking to us regarding time-limited treatment strategies in CLL. This webinar would be at 7 p.m. Indian Standard Time on the 20th of December, Friday. And I request one and all to log in for that webinar too. Once again, thank you, Dr. Francesco. It was wonderful
you.
having you.
Thank you.
And before
Thank
we
you.
wind
Thank
up,
you,
I would
Francesco.
also like to thank Emcure Pharmaceuticals for providing this platform for organizing this webinar. Dr. Srinidhi, concluding remarks from you before we wind up.
So I think it was great learning, and we are all very new in this ctDNA space in lymphoma, and we all have initial experience, and probably we can all collaborate not only in the country but also with Francesco and Dr. Umberto. And thank you everyone for joining. And if you have any questions, you can tell us, and we will email them, and we'll get back to you with their responses. Thank you so much. Have a great evening ahead.
Thank you all.
Thank you. Bye.